Hey Kirsten,
Yeah.
can you tell me a bit about intubation, please?
Yeah, what do you want to know?
Everything.
Well, that narrows it down then, doesn't it?
When can you intubate as an ICP in New Zealand?
Generally, intubation without sedation and paralysis first, or RSI, is reserved for patients with a GCS of 3 and ineffective breathing. The three settings in which you'll see that typically are during respiratory arrest or cardiac arrest, during post-ROS cares, or in a patient who's choked with loss of consciousness.
When can't you intubate?
Essentially any time outside of that setting. If a patient needs to be sedated and paralysed first, that requires an RSI endorsement.
It sounds complicated and risky. Is that so?
Yes and no. As a skill, it's no more complicated than or difficult to perform than LMA placement or IV cannulation. As with all skills in the ICP, paramedic and EMT repertoire, it's the decision not to intubate and weighing up the pros and cons or the risks and benefits for the patient that's the difficult part.
So what are some of the risks?
Well, the risks are plentiful here because the act of intubation can cause profound physiological changes within the patient. These can drastically alter patient outcomes. Some of the risks include hypoxemia during the act of intubation and laryngoscopy, dental injury due to incorrect laryngoscopy technique, bradycardia and hypotension due to vagal nerve stimulation during laryngoscopy, and conversely increased intracranial pressure due to sympathetic nervous system stimulation. Esophageal intubation can cause regurgitation and aspiration, which can cause sepsis and again can vastly worsen patient prognosis. Paramedic tunnel vision and task focus can alter ventilation rates, which can worsen states of hypoxemia, hypercapnia, worsen traumatic brain injury, and again alter patient prognosis. Positive pressure ventilation during CPR can drastically impede venous return to the heart, which decreases cardiac output. During respiratory arrest, positive pressure ventilation can drastically worsen dynamic hyperinflation, which can put the patient at increased risk of pneumothorax. And finally, overinflation of the endotracheal tube cuff balloon can cause ischemic injury to the trachea, which again worsens patient outcomes. These are just the risks associated with laryngoscopy and intubation, and it's not by any means a comprehensive complete list. Sedation and neuromuscular blockade carries its own unique set of risks. Hypotension can occur, mostly due to the action of the opiates and the benzodiazepines, but also due to decreased sympathetic nervous system activity or sympathetic tone. In hospital, it makes central nervous system activity very difficult to assess by hospital staff, and it might cause inappropriate prolonging of the dying process in patients with severe or significant comorbidities. Examples of these would be end-stage cancers, dementias, and patients who had an initial rhythm of asystole during their cardiac arrest.
That's a lot of risks. Is it worth risking deterioration of the patient's condition? Or potentially worsening the patient's outcome when we have other airway options available that are more basic but seem to have less risk?
Well, as I said, it depends on each patient and each circumstance and the ICP's own ability to weigh up benefit versus risk in that setting. Endotracheal intubation does carry with it some massively valuable benefits for the patient. It secures and protects the airway, preventing aspiration of vomit for the patient and massively decreasing the patient's risk of morbidity from sepsis. It allows for continual and effective monitoring of end-tidal CO2 levels, which is massively useful in the profoundly shocked patients. It also allows for targeted positive expiratory pressure and ventilatory control to manage end-tidal CO2 levels. It allows for continuous chest compressions to occur during resuscitation, which we know has a Class 1A level of evidence from the American Heart Association. Finally, a relatively new addition to the CPGs, is during choking, in which ICPs can advance the tube as far as it will pass and push the obstruction into the right main bronchus. Withdrawing the tube to its normal length, allowing for ventilation to occur through the left lung. This prevents death by asphyxia. While intubation is a risky skill to perform, it's actually an invaluable skill that contributes to improved patient outcomes. We've seen this in contemporary literature. The key here is effective crew resource management, with precise, efficient skill delivery and effective post-ROSC care, with the ability to tailor treatments to changing and dynamic patient presentations.
Crew resource management. How is that important for an ICP skill?
Crew resource management is incredibly important in this scenario, and in fact patient outcomes hinge on it. Pre-oxygenation, passing a tube over a bougie, ventilation and basic patient cares are all things that can happen or be done by personnel at any skill level. When done correctly, these actually improve patient outcomes.
Hey Kirsten,
Yeah?
tell me a bit about procedure for intubation, and maybe a little bit about where I all fit into the picture.
Yeah, sure. I mean, several of the key components to intubation are the same as with regular supraglottic ventilation.
First we need to position the patient in the sniffing position, aligning the tragus of the ear with the sternal notch. Yep, that looks good. What this does is it aligns the axes of the airways, allowing for maximal visualization of the soft tissues during laryngoscopy. The patient needs to be pre-oxygenated prior to laryngoscopy, ideally for 5 minutes. This increases the fraction of inspired oxygen of the patient, creating a reservoir. This allows the patient to compensate for a short period of apneic time during laryngoscopy and intubation. Prior to attempting intubation, I need to check all my gear and get it ready. I need a laryngoscope handle and blades, either curved Macintosh blades or straight Miller blades will do, with the light checked. I need a bougie and an endotracheal tube stylet. I need an appropriately sized ET tube with cuff checked and syringe attached. I need either a cloth tie or a bite block to secure my airway with. I need a filter, end-tidal CO2 probe and a Cobb's connector, a bag valve mask with a PEEP valve. I need a rescue airway and suction unit nearby and on standby. I need my stethoscope to assist with confirming tube placement, and I need appropriate PPE, gloves and safety glasses as a minimum. I of course need a defibrillator that is capable of measuring end-tidal CO2. If this is not available, that's a contraindication for intubation to happen, and intubation must not occur under any circumstance. I'm going to evaluate my lemon assessment on this patient. First, looking for potential complications with either laryngoscopy, intubation or bag valve mask application. Looking for things like large incisors, a large tongue, beards and moustaches. Next, I'm going to evaluate the 3-3-2 rule, checking that 3 of the patient's fingers will be able to fit between the incisors, between the chin and the hyoid bone, and between the hyoid bone and the laryngeal prominence. Next, I'm going to assess a Mullen-Putty score. I'm going to do this by having a look in the patient's airway, looking to the back towards the uvula, assessing how much of the soft tissue I can see. This score gives me an indication of whether or not it will be a difficult intubation. I'm going to look for obstruction or potential causes of obstruction with this patient, things like obesity, false teeth and loose flesh around the face or the neck can cause potential obstruction. The final thing is neck mobility, really making sure that the patient's neck is able to move into the sniffing position and around for laryngoscopy. During laryngoscopy, I might ask you to assist me in providing backwards, upwards, rightwards pressure to the laryngeal prominence. I'll guide your hand in doing this, and you don't need any prior knowledge. What it does is it enhances my visualization of the glottis and the vocal cords. The other thing that I might ask you to do is pass the endotracheal tube over the bougie for me and assist me with securing the tube. When the tube is secure, I may elect to delegate ventilations to you. I'll fully explain the rate and volume of ventilations that I would like you to use, so you don't need to have any prior knowledge for this. This is useful because it allows me to free my hands up to do other things like draw up my drugs.
Actually,
As you're a St. John trained emergency medical assistant, you've been formally trained in drawing up intubation and RSI drugs. So an ICP or myself might delegate this task to you. Like I said before, don't worry, we'll fully explain how we would like this done, and there'll be no ambiguity surrounding the instructions.
Hey Kirsten,
Yep.
is there any chance you can take me through an intubation scenario?
Yeah. So here we have a handy dandy patient who's been in cardiac arrest and tube ROSC. They've got spontaneous circulation but no spontaneous respiration. So we've ramped the patient, or kind of ramped the patient, and we've got them in the sniffing position with the tragus of the air in line with the sternal notch. You're pre-oxygenating the patient every 6 seconds to increase their fraction of inspired oxygen. That provides a little bit of reservoir for during the laryngoscopy and intubation. So what we're going to do on the count of 3 is you're going to step to the right there. I'm going to start laryngoscopy, and if you could just pass me the things that I asked for, that would be wonderful. Okay. Is that alright? Awesome. Okay, I'll just check my light. Alright, on 3. 1, 2, 3. So, placing the laryngoscope down the right side of the mouth, sweeping the tongue to the left, past the bougie. Wonderful, that's in. Could you advance the tube for me, please? Lovely. Okay, so I'm going to advance the tube to the second black line, which is 23 centimetres at the lips. Remove the laryngoscope. Inflate my cuff. You can remove the bougie now, thank you. We're going to secure this, so if you can just help me with the bite block. Just want to shove that in there while I'm holding the tube. Let's draw forward, there we go. Pull this up the side. Wonderful, let's attach that to the top there. Okay, so I'm going to check my tube placement, looking at my end-tidal CO2 reading, which is more than 5 centimetres of mercury, 5 millimetres of mercury, sorry. I am going to have a listen to the chest, making sure that I haven't intubated down the right main bronchus. Good air entry. Equally good air entry. And the abdomen's quiet, so that's good. I can see my end-tidal CO2 waveform looks fine, so I'm happy with that. I'm in the right place. So what we're going to do is you're going to continue to ventilate the patient every 6 seconds for me with a tidal volume of about 600 mils. What I'm going to do is I'm going to check the cuff pressure of the tube. Okay. I'm going to do this by releasing air when you ventilate until I can hear a leak, and just re-inflating with 1 to 2 mils. Ready? Go. And again. Awesome, so I'm going to re-inflate, and that's that. Awesome. So the next thing I need to think about for this patient is that in the event of any significant movement, I need to consider sedation and neuromuscular blockade.
Neuromuscular what?
Sedation and neuromuscular blockade after intubation are indicated any time that significant movement is seen in the patient. Significant movement can be defined as any observed movement or any observed attempt at respiration that can be seen through a curare cleft in the end-tidal CO2 waveform. Neuromuscular blockade allows for uninterrupted ventilations of the patient without interruption from physical movement or spontaneous respiration. Sedation is imperative for these patients, as intubation is both psychologically uncomfortable and physically painful. Positive pressure ventilation is quite different from the sensation of the negative pressure ventilation, that is part of normal physiology, and this can be quite unsettling for the under-sedated patient. In New Zealand, we use rocuronium as our neuromuscular blockade, and our sedatives are either a morphine midazolam mix or a fentanyl and ketamine mix. This is slightly different from our Australasian counterparts. Ambulance Victoria and Queensland Ambulance Service both use, for sedation, a midazolam mix with either morphine or fentanyl. During cardiac arrest or post-ROSC cares, which are the typical standard intubation settings, it should be normal practice for an ICP to elect to use the fentanyl ketamine mixture, as these patients will almost always be profoundly shocked and hemodynamically unstable. The morphine midazolam mix contains 10 milligrams of morphine and 10 milligrams of midazolam within the one syringe. This is then diluted to 10 mils, so that each mil of the solution contains 1 milligram morphine, 1 milligram midaz. This solution is given in 1 to 2 milligram doses every 5 to 15 minutes. This is titrated to effect. The ketamine and fentanyl are drawn up in separate syringes. The fentanyl syringe containing 100 micrograms of fentanyl, the ketamine syringe containing 100 milligrams of ketamine. The dose that's used here is 50 micrograms fentanyl, 50 milligrams ketamine. This is dosed every 15 to 30 minutes and is the preferred mixture for the hemodynamically unstable patient. Again, this is titrated to effect. The final drug used is rocuronium. Rocuronium is given as an IV bolus in a weight-related dose. So patients with a weight of 50 to 80 kilograms receive 50 milligram dose of rocuronium. Patients weighing more than 80 kilograms receive a 100 milligram dose of rocuronium. This can be repeated as required to sustain adequate neuromuscular blockade. Some final things I need to discuss for the completion of this OSCE video are the failed intubation drill, bougie-assisted intubation, and suction-assisted laryngoscopy airway decontamination, which is quite a mouthful. The failed intubation drill is set out quite clearly within the St. John CPGs. In the event that the vocal cords cannot be seen, that the tube can't be passed within 30 seconds of the attempt commencing, or in the event that the end-tidal CO2 reading is equal to or less than 5 millimeters of mercury, the tube must be removed and the patient pre-oxygenated again. A second attempt may occur, but this is provided that the operator changes at least one aspect of their technique. Aspects they may elect to change include changing operator if a second ICP is available, changing the patient's position to maximise visualisation of the airway structures, changing the laryngoscope blade shape and size, and utilising an airway assistant to provide assistance with bougie-assisted intubation or backwards-upwards rightwards pressure. If the second intubation attempt fails, then again the tube must be removed, but this time the ICP must revert to supraglottic airway adjuncts and basic airway cares. If the patient can't be ventilated and oxygenated, then a cricothyroidotomy or surgical airway is indicated. I've just mentioned bougie-assisted intubation. This is preferred for use by St. John ICPs when a difficult intubation is anticipated. Now this might be recognised either during the Lemon assessment or during an intubation attempt itself. During bougie-assisted intubation, an airway assistant is used. Laryngoscopy occurs as normal, and the bougie is passed through the vocal cords into the trachea, using the tactile sensation of the tip of the bougie moving along the cartilaginous rings to identify that the bougie is in place. The airway assistant then passes the tube over the bougie, and the ICP places the tube. The bougie can be removed and the cuff inflated, and then the patient can be ventilated as normal. Suction-assisted laryngoscopy airway decontamination is a contemporary technique that currently has a bit of a cult following within emergency medicine. The basic premise of this is that the right hand is used to suction the visible airway, removing any fluid obstruction. Once that's been done, the laryngoscope can be placed as normal into the vallecula and the mandible moved forward. Again, the visible field is suctioned until the fluid obstruction is removed and the vocal cords and the glottis are visible. What happens then is that the suction catheter from the right hand is parked behind the laryngoscope and held in place by the left hand. The tube can then be passed as normal as the airway has been cleared and the suction catheter and the laryngoscope removed. The patient can then be ventilated as per normal intubation. This is quite a different technique to what's historically been taught to ICPs, particularly within New Zealand, but it definitely has its place within the contemporary ICP skill set.